This is the fourth and final video of the lower limb series. In this video, I will be talking about the hip joint and the knee joint. I will be also introducing you to lumbar spine, osteology and musculature, and lastly, some surface anatomy of the lower limb. This is a hip joint, a ball and socket joint. Here the head of the femur inserts into the concave lunate surface of the acetabulum. The socket is deepened by a ring of fibrocartilage called the acetabulum labrum. On the anterior side, we can see this joint is supported by the iliofemoral ligament and the pubofemoral ligament. On the posterior side, we can see the ischiofemoral ligament, and this is the transverse ligament. Finally, this is the ligament of the head of the femur, which carries a blood vessel to the fovea or pit of the femoral head. This blood vessel is called the artery to the ligament of the head. The head of the femur normally receives blood from the medial and lateral circumflex arteries, as well as the artery to the ligament of the head. A common complication of fracture of the femoral neck is necrosis of the head of the femur due to ischemia. The blood supply from the artery to the ligament of the head alone is insufficient for healing. If the fracture prevents the medial and the lateral circumflex artery from reaching the head, then the necrosis of the head is likely. The knee joint is a synovial hinge joint formed between the femoral and the tibial condyles and the patella and the patellar surface of the femur. Attached to the tibia are the C-shaped medial and lateral menisci. The knee joint is stabilized by a number of ligaments. This is the medial collateral ligament. It strengthens the medial aspect of the knee joint. Note its attachment to the medial meniscus. It also forms the part of the capsule and strengthens the capsule medially. This cord-like structure is the lateral collateral ligament. Note it does not attach to the lateral meniscus, and it also does not provide strength to the fibrous capsule on its lateral side. This is the anterior cruciate ligament, also known as ACL. Here on the posterior aspect of the knee joint, we can see the posterior cruciate ligament, also known as PCL. The Drawer test is a useful test to see if these ligaments are intact. The anterior Drawer test is performed to check the ACL. The shin or the tibia will move slightly forward if the ACL is intact. If the ACL is torn, then the shin will move more forward or anteriorly. Posterior Drawer test. This test is performed to see if the PCL is intact. The test is similar to the anterior Drawer test. The examination would entail you pushing the shin backwards. If there is excessive movement of the shin backwards, there is an indication that the PCL has been injured. The ankle joint is a hinge joint comprised of distal end of tibia, the medial malleolus, and the distal end of fibula, the lateral malleolus. These bones articulate with the trochlea of the talus, one of the major tarsal bones. It can move in a single axis, performing dorsiflexion and plantar flexion. Remember that while the fibula is not a part of the knee joint, it is a part of ankle joint. The deltoid ligament strengthens the ankle joint on the medial side. Its three bands extend from tibia to the talus, the navicular, and the calcaneus. The joints of the foot are stabilized by 3 strong ligaments. This is long plantar ligament, the short plantar ligament, and the spring ligament. These ligaments maintain the medial and the lateral arches of the foot. Now I will demonstrate the layers of the fascia and muscles of the back. Most superficially is a thick, strong fascia called the thoracolumbar fascia. Beneath this we can see the erector spinae muscle, which consists of iliocostalis, longissimus, and spinalis muscle. Still deeper is the multifidus muscle. In this prosection, the lumbar vertebrae have been opened, exposing the contents of the spinal canal. The space between the meninges and the vertebra is called the epidural space. The only visible meninges in this section is the dura mater and the pia mater, which is very thin. The arachnoid matter was destroyed during the preservation process. Inside the meninges, we can see the cone-shaped termination of the spinal cord is called the conus medullaris. It terminates at L1, L2 disc. This is where a spinal tap is administered. This is the cauda equina, made up both spinal nerves roots and the extension of the spinal cord. Some of the bony structures of the lower limb are visible in the surface anatomy in thin individuals. In the anterior hip, we can feel the anterior superior iliac spine, or ASIS. On the posterior surface of the hip, we can see these dimples, known as the dimple of Venus. They mark the location of the posterior superior iliac spine. On the superior part of the hip, the iliac crest forms the sharp ridge. This bone is useful for bone grafting since it is close to the skin. On the ankle, we can see the medial malleolus at the distal end of the tibia and the lateral malleolus at the distal end of the fibula. There are 3 important pulse points in the lower limb to detect blood flow. These are the femoral pulse, felt at the midpoint between the pubic symphysis and ASIS. In this region, the femoral vein is medial to the femoral artery and the femoral nerve is lateral. The popliteal pulse is felt in the popliteal fossa against the tibia. The dorsal pedis pulse can be felt here on the dorsum of the foot.